Hello friends, now I am going to discuss about disorders of the esophagus. Disorders of the esophagus are acute esophagitis due to the inflammation. It is due to the ingestion of hot liquids, corrosives and lacerations due to foreign body or esophagoscopy during esophagoscopy and infections like moniliasis and systemic pemphigus. Pemphigus is the autoimmune disorder which affects the mucosa. Then coming to perforation. Perforation may be instrumental or spontaneous. Instrumental perforation involves mostly the above to the upper esophageal sphincter, and spontaneous rupture it involves mostly the lower third part of the esophagus, and it is mostly after vomiting. And the Boer-Haave syndrome. Boer-Haave syndrome is the post-emetic rupture of all the three layers of the esophagus. Post-emetic rupture of all the three layers of the esophagus is called Boer-Haave syndrome. Coming to the diagnosis and clinical features. In case of cervical esophageal rupture, there is pain, fever, dysphagia, local tenderness and surgical emphysema. Coming to thoracic esophageal rupture, pain is referred to interscapular region, surgical emphysema, fever, and there is crunching sound over the heart. Crunching sound over the heart due to air in the mediastinum. This is known as Hammond's sign. Hammond's sign. Diagnosis is made by X-ray chest and neck. Treatment: massive doses of antibiotics IV and nutrition IV is given. Oral feeds are stopped immediately. In case of thoracic esophageal rupture, in early diagnosis, within 6 hours of the perforation, surgery is done and pleural effusion is done. In case of delayed, surgery is restricted and infected area is drained. Then coming to corrosive burns. Corrosive burns are due to acids, alkalis and chemicals. And the nature of the burns or the severity of the burns depend on the nature, its quantity, concentration and the duration of the contact. Pathology. Initially there is necrosis, granulation and stricture formation. Stricture begins at 2 weeks and continues to 2 months and longer. Treatment by giving IV fluids, antibiotics, steroids, esophagoscopy. Steroids to prevent stricture within 2 days. Coming to benign strictures. The causes are burns, trauma, ulcer and congenital. Trauma may be due to foreign bodies or instrumental. Ulcers due to infections like diphtheria, gastroesophageal reflux disease. And in case of congenital, lower third of the esophagus is mostly involved. Clinical features. Dysphagia first to solids and then later to liquids, and also cough. Diagnosis by barium swallow and esophagoscopy. Treatment: if the stricture is permeable, dilatation is done. If not permeable, gastrotomy and retrograde dilatation are done. If impossible, surgical excision of strictured part is done. Impossible in the sense there is no chance of dilatation of stricture. Then coming to hiatus hernia. Hiatus hernia is a displacement of the stomach into the chest through the esophageal opening of the diaphragm. Displacement of the stomach into the chest through the esophageal opening of the diaphragm. It is of 2 types, sliding and paroesophageal. In case of sliding, stomach is pushed into the thorax in line with the esophagus. In case of paraesophageal, a part of the stomach along with peritoneal cavity passes by side of the esophagus. Here, stomach is pushed in line with the esophagus. Here, stomach passes by side of the esophagus, side of the esophagus. Clinical features in sliding are ulcers and stenosis. Paraesophageal dyspnea on exertion. Treatment: surgery. If those who are unfit for surgery, conservative measures are taken. Avoid smoking. Reduction of obesity. Decrease drugs like antacids, protein pump inhibitors, and sleeping with head and chest raised. Attention to the causes that raises intra-abdominal pressure.